should be start. Okay, hello everybody. My name is Kambiz Nael. I'm one of the neuroradiologists at Mount Sinai, New York. And it's a pleasure to be here. I'd like to thank everyone for attending this meeting, and I'd like to thank Olea Medical for inviting me and setting up this meeting so I can share my experience with you on use of perfusion imaging and cerebrovascular disorders. So my disclosures. So if you look at the treatment considerations for acute ischemic stroke, we have come a long way since the landmark study by NINDS back in 1995 when they approved the use of intravenous TPA for treatment of stroke. And it took us almost 20 years to get to where we are right now, where in 2015, mechanical thrombectomy was declared the new standard of care for patients with acute ischemic stroke. So in terms of our management, if you look at it, haven't really changed that much. Maybe there's just a little shift in the paradigm, but there are still, at least in the US, we have all these basic stroke centers that they do non-contrast head CT and to rule out hemorrhage, to confirm the presence of ischemia or stroke, and then they treat with intravenous TPA. And we have also advanced more comprehensive tertiary stroke centers where they do more advanced imaging, including CTA, CT perfusion, MRA, MR perfusion, and they have basically access to endovascular treatment and mechanical thrombectomy. So in terms of imaging, as a neuroradiologist, we still have the two options that we all know of, CT stroke protocol, in which you can do non-contrast head CT, CT angiography, and CT perfusion. It's a very fast technique, and it's broadly available, so it's by far the most common methodology, at least, again, in the US, I'm pretty sure same here, that we use for to image acute stroke patients. You can also use MRI. In fact, there are some centers that they use MRI. They like to take advantage of specificity of diffusion with imaging to include or to basically identify the infarction core. So they have a big advantage over CT. And it can be fast. So in like a routine MR stroke protocol, you need diffusion imaging, you need FLAIR and GRE, you need MR perfusion and MRA. And with the new techniques, you can actually accelerate your acquisition. In fact, a couple of years ago, we published a study in stroke, basically introducing this 6-minute stroke protocol using parallel imaging and EPI technology to accelerate our acquisition time. And we basically use contrast injection to do a supraortic arterial MRA from arch all the way up to the vertex, and then finish the study with MR perfusion. So it can be fast acquisition time. I don't think that's a limitation. It's really the logistical issue of your institution. If you have everything in place, you can use MRI for stroke patients. But again, far less than CT has been used. So the objectives of this presentation is to go over the common applications in which I use perfusion imaging for in patients with cerebrovascular disorders. We're going to review how perfusion imaging can improve diagnosis in patients with TIA. And how it can be used to exclude stroke mimics such as seizure. We review how perfusion imaging can provide opportunity to image physiology, and we touch base on cerebrovascular reserve imaging and collateral flow imaging. And at the end, we will talk about how perfusion imaging can be used for tissue characterization. We go over penumbral imaging a little bit, and also how it can be used to predict hemorrhage in patients with acute ischemic stroke. So TIA, as many of you know, it's a diagnostic challenge, especially in the emergency department. A patient, they present with some neurologic symptoms. It's a temporary, and usually they get resolved. And, often they get CT or MR. Like this was a case I have here for you. It's a 67-year-old man who presented with 15-20 minutes aphasia, had a head CT, which was normal. At an MRI, I have here diffusion images for you, which didn't show any evidence of infarction. There is an MRA of the neck and brain, which again didn't show any arterial occlusion or proximal stenosis. And then perfusion imaging, you see that there is a regional perfusion delay. If you look at the mean transient time in the parietal temporal junction here, and on the cerebral blood flow, I think I have magnified images here, so you can see that there is some delayed perfusion on mean transient time, and there is minimal asymmetry in cerebral blood flow. And CBV, if anything, actually you may have increased blood volume on this side, which would be an indication of autoregulation. So in our experience, perfusion imaging can help identifying patients with TIA. And about 25% of our TIA patients diagnosed with MR perfusion, which otherwise have completely normal MR, including MR angiography. I published this again last year, and this is really in concordant with the result of previously published studies. Anywhere between 25 to 35% of TIA patients may have regional perfusion deficit that would indicate a footprint of ischemia in these patients. And that's really, you can justify that by looking at the spectrum of hemodynamic impairment. The numbers to remember is about 40 cc per minute of blood flow. That's below that you get to the algemic area, and when you get to 20, you can have some electrical dysfunction and start getting symptomatic, and then below 10 is the critical hypoperfusion, at which you can develop infarction, which you can pick up with diffusion-based imaging. But I think the perfusion imaging, the role of perfusion imaging is to pick this part of hemodynamic spectrum for anywhere from 10 to 40. I have a couple of more examples to show you. This was a 22-year-old woman presented also with aphasia, completely normal, diffusion, flare images, MRA is normal, no stenosis. And I have here ASL for you. You can see that, again, there is a regional perfusion deficit in that very close to Wernicke's region, which basically was explaining this patient's aphasia. This was a 64-year-old man who presented with right-sided weakness. Have diffusion and flare images. There's some mild chronic microvascular ischemic type changes on flare, but otherwise no infarction, and MRA here, no proximal occlusion or stenosis. And if you look at perfusion imaging, I have the Tmax maps here. You can see that there is a regional perfusion delay in the opercular region. Again, if you look at CBF, there is no real asymmetry. If anything, you may have slightly increased cerebral blood volume in this region. And again, that's really the autoregulation. So it's the brain that is trying to maintain cerebral blood flow in order to avoid basically infarction. This patient was discharged with a diagnosis of TIA, and he came back 24 hours later with worsening of thickness. And this is his diffusion imaging. We can see that there is developing diffusion signal in that region, indicative of ischemia in the new scan. So how perfusion imaging can help you to diagnose stroke mimics. I'm going to talk about seizure a little bit. I think that's another problem in emergency departments. So this was a patient who was seen by a stroke team, a 90-year-old woman presented with confusion. She was assigned an stroke scale of 14. And I have here, this is part of our 6-minute stroke protocol. You can see the EPI flare images. She had moderate amount of chronic microvascular ischemic type changes. There is very subtle diffusion signal here. I don't know if it's projecting well, but you can see that there is some subtle diffusion signal with some dark ADC, corresponding ADC signal. That also involves the pulvinar aspect of the thalamus here. And I think should have magnified images. Again, diffusion signal may be subtle, but no subtlety here on perfusion. You can see clearly very rapid perfusion imaging along their left cerebral hemisphere. Parietal occipital junction is significantly involved. You can see cerebral blood flow significantly increased, cerebral blood volume significantly increased, and that's a very classic presentation of patient with seizure. So again, on diffusion scans, you can look at the parietal occipital cortical ribbon, the pulvinar sign that has been described in patients with seizure, And then if you don't see that on diffusion, then you always have this perfusion to help you. It's luxury perfusion that you see with a patient with seizure, clearly crossing vascular territories. It's not MCA only, it's MCA and PCA. Pulvinar aspect of thalamus, not very well seen here due to slice thickness, but you see that on diffusion signal. This was a follow-up CT in this patient who basically doesn't show any evidence of infarction. She was recovered after seizure treatment. So post-ictal diffusion, perfusion signal changes. It's really a sequela of obviously prolonged brain activity. So if you have prolonged ictal activity, there is increase in metabolism, glucose utilization. As a result of that, there is increase in blood flow in order to meet the metabolic demand, and that's where you start seeing increased perfusion in those regions. And if there is uncoupling between blood flow increase and the utilization of the glucose, then if it's prolonged enough and severe enough, then you would develop restricted diffusion on your diffusion weighted images. So how the affected areas, again, cortical ribbon, very classically, parietal occipital junction is the most common location to get involved. Hippocampal formation, often you see that, and the pulvinar of thalamus, not commonly seen, but when you see it, it's very characteristic for patients with seizure activity. And you see how to differentiate that from infarction. Obviously, you have luxury perfusion, not hypoperfusion. It crosses vascular territories, and again, look for pulvinar sign. So this was a 60-year-old woman presented with right-sided weakness. You see, again, on diffusion, very subtle, just cortical ribbon. There is some signal, increased signal here. I don't know if it's reflecting well, but again, on perfusion, you clearly see that there is a symmetric increased perfusion on cerebral blood flow. And again, MRA is normal. This was a patient who had the seizure. I have ASL actually here for you. So this is a whole brain ASL, and you can see that there is increased perfusion in the parietal lobe, temporal lobe, and if you go further down, you see the hippocampal gyrus and parahippocampal formation is also involved. Again, she received seizure treatment. Again, that's the baseline increased cerebral blood flow we have, and 48 hours later, we have the scan that doesn't show any evidence of infarction, and the CBF basically went back to normal after resolution of post-ictal phase. So moving on to the next topic, how perfusion imaging provides opportunity to image physiology. We're going to go over cerebrovascular reserve imaging. That's something that we do it routinely in our practice, and I have several examples here to share with you. So when you have chronic arterial occlusion, there is a decrease in capillary perfusion pressure, or CPP, and eventually, if that is maintained, then you would have decrease in cerebral blood flow, which can result in ischemia and eventually infarction. So the brain defense, at least one of the brain defense, there are several layers, but one of them is the autoregulation, and at which there is arterial vasodilatation to increase the blood volume to that territory that is involved in order to maintain the cerebral blood flow. So this area under the curve is basically your cerebrovascular reserve. So again, there is a decreased capillary perfusion pressure. CBF needs to be maintained in order to avoid ischemia and infarction, and that is done by increased arterial vasodilatation and cerebral blood volume. So it's essentially brain ability to maintain CBF by vasodilatation. And you can measure this by using challenge perfusion, often done by Diamox, which is an arterial vasodilator. So you give Diamox, and you calculate the cerebrovascular reserve index, which is the CBF after Diamox minus the baseline divided by the baseline multiplied by 100%. Initial data in the literature is on the use of SPECT, cerebrovascular reserve index, basically, but there are several papers came out. The most recent one last year published in Radiology, when they look at ASL Diamox challenge study, compare that against SPECT, and they found a diagnostic accuracy of 85%. So it's a relatively good technique, and again, we offer this as a clinical service in our institution. Let's go over some cases here. This was a 50-year-old man presenting with TIA, and the CT scan, CTA that was done, see that there is this carotid occlusion. On the right side, there is internal carotid occlusion right after the origin. And basically, the question is whether to treat or not, and when you need to treat. This patient had contraindication to MR. That's why we did CT perfusion with Diamox here. So I have the baseline CT perfusion. These are the CBF maps. So you can see that there is decreased CBF along the right MCA distribution. And when we give Diamox, after Diamox, you can see that there is no significant increase in this patient. If anything, actually, it's slightly lower. So you can track these using different perfusion technique or software that you have. Here you can see that if you look at the baseline and the post-Diamox, there is clearly the cerebrovascular reserve index is below 0, which is indicative of impaired hemodynamic response. This patient was followed by MRI, and you can see that he's developing watershed infarctions. So obviously he needed to be treated rather urgently, as opposed to waiting. The disadvantage of CT perfusion, if you do Diamox CT perfusion, is you need to do 2 sets of CT, and the radiation dose is not insignificant. So unless there is a contraindication for MR, we really don't offer CT perfusion because you don't really have to. And I show you a couple of examples with ASL. This was a 61-year-old man with left ICA occlusion. You can see on CT, there's clearly occlusion of the entire ICA. This is the angiogram. You can see again occlusion of the ICA. Maybe there's just a little thread of contrast going in. And this is the MRI, which basically shows there is infarction developing in the temporal and the insular region. And this was a failed attempt at revascularization. So they basically tried to pass the occlusion, and they employed stent, which didn't really work, unfortunately, in this patient. So they decided to follow this patient with the Diamox 4 weeks after stroke onset. So this is basically her diffusion sequences here. Your flare, you see that there's some foci of developing infarction, but no new diffusion signal. And this is the baseline ASL perfusion. You can see that there is some delayed, or I should say hypoperfusion. These are CBF maps from ASL. And after Diamox, you can see that there is clearly increased perfusion in the entire cerebral hemisphere, including the MCA distribution on the left side. And if you calculate the cerebrovascular reserve index, was ranged between 30 to 40%. So this was a normal Diamox study in this patient. So basically, they decided to follow this patient and not reopen that artery by surgery. This was a 42-year-old man with left MCA dissection. So this was an initial presenting CTA that showed basically occlusion of the MCA on the left side. And that's the angiogram. There you can see that, again, there is a very small thread of contrast, but not much opacification of the MCA distribution. This was stented, successful recanalization with TK2B. And this is the post-stent CTA, which shows clearly that there is opening of the artery. This patient was followed 6 months later with angiogram. You can see he developed significant intimal hyperplasia. There's very small, again, lumen. But if you look at the rest of the injections and the follow in the later phases, you can see that this patient has very good opacification of the distal MCA branches, and there is good collateral flow, basically. So again, they decided not to treat that intimal hyperplasia, and we have an MR Diamox study that was followed by that angiogram, and you can see these are the chronic infarction that he had, no acute infarct, and again that's baseline ASL, and then we have the after Diamox, again left MCA, there's asymmetry of cerebral blood flow, but there's clear increase in cerebral blood flow in that region after Diamox. And again, the CVRI was ranging from, anywhere from 30 to 40%. So this was a normal maintained cerebrovascular reserve. Just follow that patient. I'm going to end with this case here, 34-year-old man with some sort of vasculopathy. It wasn't moya. It's basically the MCA only. The right MCA was the only vessel that was involved. He was presenting with repeated TIA symptoms, and the question was whether he needs bypass or not. And again, very normal brain MRI. These are the flare images. These are diffusion and ADC maps. No evidence of infarction, acute or chronic. So obviously you would think that this patient should be okay. But we did the Diamox. In this patient, we did actually the Diamox challenge using DSC perfusion. So these are the DSC before, and these are the DSC after Diamox. And you can see that there is delayed mean transient time at the baseline, and after Diamox, that is resolved. And look at this cerebral blood volume here, so you can actually see that how much CBV is increasing in order to basically maintain the cerebral blood flow. These are the maps that you can track baseline and after Diamox, and this patient had more than 40% increase in cerebral blood flow, so normal hemodynamic response, basically. Going to the topic of collateral flow imaging. Collateral flow, as you know, it's a hot topic in stroke these days, especially since now we have endovascular treatment, and we are trying to extend our treatment window in order to treat these patients. So having a good collateral flow is associated with better outcome in patients with acute ischemic stroke. It basically maintains cerebral blood flow beyond the clot, so it decreases the infarction growth rate, and also it increases the therapeutic window that you may have. Also, it delivers endo and exo TPA to the clot from the other side, and that increased the recanalization rate, and also it increases the recanalization rate, and it can decrease the rethrombosis rate in patients with acute ischemic stroke. The way that normally it's been done, or at least the gold standard right now is DSA, basically catheter angiography. There is the American Society of Interventional Neuroradiology scoring that goes from 0 to 4, 0 being no visible collaterals, 4 being perfect, complete, basically blood flow to the territory that is involved with rapid filling of the arterial tree. But you really want to identify collateral flow before you take the patient to cath lab. And that's the ideal, at least, because since you do the non-invasive imaging, including CT or MR, it would be very helpful to get a sense of collateral status in your patients to see whether, when you take the patient to cath lab, whether you have more options in order to treat these patients. So it's been investigated extensively in the literature. People looked at CTA and MRA, which basically provides you the anatomic information, and you can see direct visualization basically of the collateral vessels by doing angiography, whether it's CTA or MRA. And also people looked at CT perfusion and MR perfusion. They provide dynamic functional information, and they provide a measure of efficiency of collateral perfusion via leptomeningeal and secondary collateral pathways, which are otherwise not seen by direct CTA or MRA. So collateral perfusion is characterized by two components. There is a delay component, which is adequately evaluated with time maps, like let's say mean transient time or time to peak or Tmax. And then there is also a dispersion component, which is evaluated by cerebral blood flow and cerebral blood volume. So if you look at the literatures, the articles in the literature, these are a few papers that I could find when I was putting this talk together. So better collaterals have been associated with milder perfusion defect if you're using perfusion imaging to identify your collateral status. So Bang in 2008 showed that better collateral is associated with larger volume of mild Tmax, ranging between 2 to 4 seconds. Marks back in 2014, they showed a smaller volume of Tmax of critical hypoperfusion using Tmax of more than 6 seconds is associated with better collaterals. And Nicoli also in 2014 showed basically find the similar finding using arterial tissue delay, which is essentially a Bayesian estimated Tmax. So if you use Bayesian technique to calculate and process your perfusion imaging, that's the equivalence of Tmax, that's arterial tissue delay. But what was ignored, I think, in these papers was the fact that they only used time maps and not really looked at the cerebral blood flow and cerebral blood volume, so they're inadequately addressing the dispersion component of perfusion. I'm going to show a couple of examples and then share with you the result of our study that we did a few months ago. So this was a 60-year-old man presented with right-sided weakness, aphasia, and a stroke scale was 14. You can see that there is a dense MCA sign, and then there's evolving infarction here, the basal ganglia. And if you look at the CTA, clearly you can see that there is occlusion of the left M1 segment, but there is some collateral vessels that you can see along the left MCA distribution. I don't have the dynamic images here for you. And then if you look at the perfusion, you can see that there is a large volume of delayed perfusion if you use TTP or Tmax along the left MCA distribution. But look at the CBF and CBV, you can see that not only CBV is not decreased, it's actually increased compared to the other side. And that's what is a sense of that dispersion component of collateral perfusion. So you don't have delay, you actually have a lot of collateral flow coming in and maintaining that part of the brain. And if you look at the fusion signal, despite having left M1 occlusion, this patient only had a small basal ganglion infarction, and the rest of the territory was involved and was not involved and was revascularized. So another example, 78-year-old man, on a Stroke scale of 10. He had a right internal carotid dissection. You can see a small thread of contrast here. There is reconstitution of flow at the supraclavicular segment. Very difficult to say. This is an early arterial phase MRA, obviously. Difficult to say anything meaningful about the degree or extent of collateral in this patient. But if you look at MR perfusion, you can see a very large Tmax lesion, so hypoperfusion involving the right MCA distribution. CBF is decreased, but look at the CBV and they compare that to the contralateral. So, and there's significant increase in CBV. And again, that's a measure, indirect measurement of collateral perfusion in this patient. If you look at the diffusion, you can see that there is very small focus of infarction, and the remainder of that brain is still intact and not infarcted. So we decided to develop a multiparametric MR perfusion model to predict collateral status. We included patients with acute ischemic stroke who had MR perfusion and then DSA to score the collateral. We looked at 108 patients, and we have to exclude a significant number of them, unfortunately. 61 patients were excluded because they didn't have adequate DSA injections for us to score collateral. That's the reality. A lot of these patients, basically, they go to cath lab, and the goal is to open the artery, so you're not going to inject all these 4 different branches to get a good sense of collateral flow. Therefore, we have to exclude a big part of our patient. But 39 patients met our inclusion criteria. 22 of these patients had good collaterals, having the ASITN score of 3 and 4, and 17 have assigned as having insufficient collateral. So we look at our MR perfusion, different parameters. This is a busy table here, but I want to bring your attention to just a couple numbers here. So patients with good collaterals, they have a smaller volume of critical hypoperfusion using arterial tissue delay of more than 6 seconds. And they have a larger volume of moderate hypoperfusion using arterial tissue delay between 2 to 6 seconds. And if you look at the cerebral blood volume, again, the patient with good collateral has significantly higher CBV compared to patients with insufficient collaterals. So when we look at diagnostic accuracies, the best single parameters that gave us a good result was moderate, so volume of moderate hypoperfusion using arterial tissue delay between 2 to 6 seconds. That gave us an overall diagnostic accuracy of 82%. And the CBV also was good with overall diagnostic accuracy of 85. Interestingly, when we use this parameter that we define as perfusion collateral index, that's basically the volume of moderate hypoperfusion multiplied by its own cerebral blood volume. Then we increased our overall diagnostic accuracy to about 94%. This was presented in stroke and in ISC last year, and it's under review currently. But again, this is a multiparametric approach using arterial tissue delay and cerebral blood volume combined in order to get a better sense of collateral perfusion. I'll show you here 2 examples. Very similar looking patients, so they both have right MCA distribution infarction. One of them has a good, this mouse is, there you go. So one of them, this patient has good collateral score, and this patient has poor collateral score. And if you look at the volume of infarction, they're very similar, a small, relatively speaking, small area of infarction. The patient with good collateral has a very small critical hypoperfused volume, but has a very large volume of moderate hypoperfusion compared to the other patient. And if you look at the CBV in that region, clearly has a lot more CBV. Just looking at it, you can see that there is a lot of CBV in that region compared to patient with good collateral. If you lose perfusion collateral index, these are the numbers that we have, and our threshold currently is about 61. So if it's more than 61, that is an indication of patient with good collaterals. So moving to the last topic of this talk, how perfusion imaging can help to characterize tissue. We're going to quickly talk about penumbral imaging, and then also a prediction of hemorrhage in patients with acute ischemic stroke. So penumbral imaging historically was the main purpose of doing perfusion imaging in patients with acute stroke. It's been controversial. There are trials came out a few years ago, including DS2 and MR Rescue, which basically didn't show any benefit of doing perfusion imaging in selecting your patients for treatment. But there are some trials that came recently, and they show that may have some benefit. There's no correct answer, in my opinion, at least not yet. There are ongoing trials, including Diffuse 3, which should shed more light on this topic, and we'll wait for the result of that. But potentially, the purpose of penumbral imaging is to identify what part of brain you can salvage, or you can basically, it's not infarcted, and there's potential to go to infarction, so you can save that part of the brain. It's been a target of thrombolysis and neuroprotective agents. And if you're doing MR, then it's extremely easy, in my opinion, because you already know what the core is from your diffusion-weighted imaging, and you just pick one of the other time maps, such as TTP, MTT, Tmax, and then you identify what part of that brain or what part of that hypoperfused volume should be assigned as penumbra. If you use the number that came out from diffuse trial, that's Tmax more than 6 seconds, so that volume has been classified or assigned as potential penumbra. So in this patient, you can see that there is a small infarction, but a larger Tmax volume of more than 6 seconds, and that's potentially your penumbral tissue. This was a 79-year-old woman presented with aphasia and right face numbness. You can see that there is right parietal lobe infarction. There's a larger area of Tmax more than 6 seconds. Again, you see, I want to bring your attention that the CBV is not decreased. If anything, is actually increased. So that's the collateral flow. That's basically the brain trying to keep that part, the rest of that region of penumbra, basically try to maintain that from going to full infarction. If you recanalize that part of the arterial tree that is involved, then the idea is that you can save that, and if you do not, then that should go to complete infarction. This patient, this was a very distal occlusion at the cortical branches, so it was not a target for embolectomy or any kind of endovascular treatment, unfortunately. Just TPA, the best we could do. And you can see that it did not just recanalize. So if you look at the 24-hour MRI, you can see that entire region basically went to infarction, and that matched the Tmax of more than 6 seconds very well. Again, nothing. This is not a clinical, like a level 1 basically data. It depends on your interest and your institution, but that's what we use basically. If you use MR, then we use Tmax of 6 seconds or more as an indication of collateral, indication of penumbra tissue. This was a 56-year-old woman presented with left-sided weakness. You can see that there is a right MCA occlusion. This patient this is the baseline diffusion images here. You can see that there is some infarction and a larger area of Tmax more than 6 seconds. This was a 40 cc volume of hypoperfusion or penumbra. This patient was treated with embolectomy. You can see the recanalization of the MCA. And these are the post embolectomy MRI. Again, these are EPI flare images here. I have always a part of our 6-minute protocol. You can see the infarction grow just very small. It was 10 cc, now it's 15 cc, and that the entire region of penumbra has been resolved after embolectomy, as you expect to see. If you do CT perfusion for penumbral imaging, I think that's a completely different story. It's been challenging. I think it's still challenging, at least in our institution. We do a lot of these, and we try to find the best threshold we can. These are the data that I have from literature for you here. This is a Wintermark study back in 2006 in which he used the relative mean transit time of more than 145% as a good indication of penumbra, and cerebral blood volume less than 2 is a good indication of core. He had very good overall diagnostic accuracy, AUC of 96%. Then we started moving towards cerebral blood flow, not cerebral blood volume, to identify the core. And in most recent studies, at least, they're using cerebral blood flow, relative cerebral blood flow less than 30% as a good indication of basically infarction core. And this was by Campbell back in 2012. He looked at 49 patients, and he had overall AUC of 87%. So I'm going to show you some examples and basically show you what we use in our institution. So this was a 79-year-old woman with left M1 occlusion. You can see that the dense MCA sign here. There is some infarction. There is some loss of grade white differentiation. And these are the baseline CT perfusion. So I have Tmax maps here. These are basically the Bayesian estimated Tmax, or arterial tissue delay. And I have cerebral blood flow, cerebral blood volume. You can see, depends on what methodology you want to use. If you use the cerebral blood volume, that's basically your core. And if you use a low CBF, then that would be your core. And they are not exactly identical. There are differences between them. And then if you use Tmax of more than 6 seconds, then you can calculate how much penumbra you have. Based on this CT perfusion, we decided not to treat this patient. We thought that this core was too large to be treated. And this was the automated core estimation that we have using Olea software. And you can see that there was using cerebral blood flow less than 30%. Within the region of Tmax of more than 2 seconds, we have 98 cc of infarction. And then this is the MRI that was done 75 minutes after CT. So we decided not to treat the patient. We sent the patient to MRI. And I have here for you the diffusion signal. And you can see that there is a very large infarction. And interesting thing is that this patient infarction is relatively acute. So you can see that there is very minimal flare change. Despite that this MRI was done 75 minutes after CT, still no significant flare signal. So this was a hyperacute patient in terms of timing, perfect patient to get treated, but the volume of infarction was too high for us to basically intervene in this patient. Again, that's controversial. Depends. Some people, they don't think volume should be considered as an indication, but that's what we decided to do with this patient. So if you look at the automated infarction core estimation, it was 98 cc, and this is the MRI. And it was 120 cc using ADC of less than 600. Again, it's not 100% correlating with the region, but I think your goal really when you do CTP is to get an estimation of core. And in our institution, if the core is below 50, 60 cc, those patients, they get treatment. A lot of other factors come to play, but that's really what you expect to get from your CT perfusion. And what is the core and how much infarction you already have. So I think this CTP actually did us very well for what we intended to do and to use it for. I'm going to show you another example. 65-year-old man with right MCA occlusion that was recanalized. You can see that there's very good recanalization here after stent retrieval treatment. And these are the automated analysis. So if you look at these are the Tmax, the maps with Tmax more than 6 seconds as an estimation of penumbra. Again, you can see that it's not perfect. There's some noise, right? And then if you look at the core here, there are all these spots that is detected as potential core using cerebral blood flow less than 30%. It's 18 cc. And if you compare that to the follow-up MRI, again, the correlation, I wouldn't say it matches completely, but again, it would give you what you need to know, and that's really the core, estimation of core. So, we estimated this core as 18 cc, and we decided to treat this patient. And, if you look at the MRI, it was, relatively close. So that's our intention using CT perfusion to identify, get an estimation of basically infarction core. The last topic is how perfusion imaging can be helpful and can be used to predict hemorrhage in patients with acute ischemic stroke. So parenchymal hemorrhage can be a devastating complication of stroke treatment. It has been associated with many factors, including patient's age, infarction size, NIH stroke scale, thrombolysis, whether you treat that patient or not, time to treatment, and reperfusion. But there are also some imaging features that are associated with increased risk of hemorrhage. So having very low ADC values in the infarction core has been associated with higher risk of hemorrhage, having increased permeability in the infarction core, and also very low cerebral blood volume within the infarction bed. These are the factors that are associated with higher risk of infarction, higher risk of hemorrhage in patients with infarction. So we decided to develop a multi-parametric model using basically a baseline diffusion and perfusion values to predict basically which patient will develop hemorrhage after thrombolysis treatment. So if you look at the baseline images, the goal was whether you can identify this outcome in this patient basically. So we look at MR rescue trial data. We basically included all of their patients. We included patients who had anterior circulation stroke and had peri-treatment MR perfusion diffusion, and then had a follow-up imaging within 7 days to evaluate for parenchymal hemorrhage. Then we basically created a volume of interest of the diffusion hyperintense signal, basically, and then we did image co-registration. And we calculated, we basically overlaid this volume of interest over ADC. We did histogram analysis and calculated 10 percentile ADC values as the lowest possible representation of ADC within the infarction bed. We did the same thing for cerebral blood volume, and we calculated 10 percentile CBV values, again, as a lowest representation of cerebral blood volume. And for K2 maps, we basically calculated the 90th percentile to have the highest representation of leakage and permeability in these patients. So I have a couple of just brief tables here. This was our result. Patients, it included 83 patients. 20 of them have parenchymal hemorrhage, 63 with no parenchymal hemorrhage. In patients with parenchymal hemorrhage, they have lower value of ADC and CBV and higher value of permeability or K2 within their infarction bed compared to patients with no hemorrhage. Then we look at the diagnostic accuracies, and basically the best single parameter was cerebral blood volume with overall diagnostic accuracy of 82%. That's really in accordance to what is published in the literature. And if you look at the specificity, it ranged really from 58% to 69%, so none of them fantastic. Excuse me. But I think the major advantage of this approach was when we combine cerebral blood volume with permeability with K2. So 10 percentile CBV plus 90th percentile K2 increase our diagnostic accuracy and specifically increase our specificity to 87%. So this was just published last month in Stroke, and again, this is the classification tree I have here for you. So if you have cerebral blood volume more than 0.47, you would not have any parenchymal hemorrhage. If you have 10 percentile CBV value less than 0.47, then that would be the category that you would have your parenchymal hemorrhages within. And then you will look at the K2. If the K2 is more than 0.28, then 18 out of 20 parenchymal hemorrhages would fall in that category. So again, it's relatively fast. It's something that you can do because you can do this automated segmentation feature. And you calculate the 10 percentile RCBV, the 90th percentile K2, and using this classification tree, you can identify whether this patient would have hemorrhage or not. So in summary, we review current applications of perfusion imaging in cerebrovascular disorders. We reviewed how perfusion imaging can improve diagnosis in patients with TIA and exclude stroke mimics such as seizure. We reviewed perfusion imaging applications in cerebrovascular reserve imaging and collateral flow, and how perfusion imaging can be used in clinical practice for penumbral imaging and prediction of hemorrhage in patients with acute ischemic stroke. And with that, I'd like to thank you very much for your attention. Any questions, since there is no moderator? No questions. Okay. Enjoy the nice weather outside.
This session was recorded.